Okay, good morning everyone and welcome to another day of PPT for Year 3. This is Block 31 Masterclass 3 and it's welcome from me and Richard.
Hello.
So I'm going to turn on the music now and then at this point I'll post up onto Blackboard. If you're watching this on a rewatch or catch up, jump forward 15 minutes to catch the actual start of teaching. And I hope you find this particular PPT masterclass helpful in your studies. Any feedback you have would be welcome. Feel free to email me on david.hepburn@games.ac.uk.
The dreams. The dreams.
We could go. Something might be out there. Are you listening?
Well, good morning, everyone. It's a fine Friday morning. It's now 9 o'clock or just after 9 o'clock on the 1st of September. It's a welcome from me and from Richard. We're hoping a few more people will come and join us. To those of you who have already joined us live, welcome, and we hope that you'll be able to ask us some questions and maybe answer some of ours as we go along, just to give us a good level of interactivity. This is Masterclass 3 for Block 31. So we're kind of unashamedly switching away from cardiology and instead are switching over to do some element of respiratory medicine. But we're going to use the infections in respiratory medicine to also trigger some outcomes in relation to antimicrobial therapy, and in sort of the latter part of the first session this morning to talk about rational prescribing and antibiotic stewardship. So we're going to bash on. It's good to see you again. If there are any audio glitches or anything, if I accidentally leave the music on, if I don't flick from one scene to another because I'm being an old duffer, then let me know on the chat. Richard will keep me right, as usual. And we hope you find this masterclass useful. So there are a number of learning outcomes. Again, I'm not going to read through these because they're all on Blackboard, and I'm sure you can work through them and stick them on an Excel spreadsheet or whatever you do to track your outcomes. So this is Frances, and Frances is 54 years old, and she has a history of difficult to control hypertension. She has hypercholesterolemia and type 2 diabetes. She presents with increasing breathlessness, an intermittent fever, and she's got some pain in her left chest when she takes a deep breath. Her regular, still waking up this morning, her regular medication is a ezetimibe, lisinopril, indapamide, spironolactone, simvastatin, and verapamil. So those of you who've been with us in previous masterclasses will know that I think when you get a list of drugs like this, the very first thing to do when you scan down it is to think, are there any of these drugs that I don't know what they are? So in your own mind, you should run through the list and say, okay, I may not know a huge amount about this, but what class is it from? So hopefully you know that ezetimibe is used often alongside a statin like simvastatin further down the list to limit cholesterol reabsorption during the cholesterol enterohepatic cycle. Lisinopril is an ACE inhibitor, indapamide is a thiazide-like diuretic, spironolactone is an aldosterone antagonist, simvastatin, as we mentioned, is a statin, and of course it has statin in the name, which makes it dead easy for everybody, and verapamil is a non-dihydropyridine calcium channel blocker. You won't often see it prescribed these days, but hey, we're in a therapeutics masterclass, so we're going to throw some drugs in now and again just to make sure you're familiar with them and have seen them. So when you examine Frances, she is speaking. Resps are elevated at 26. SATs are reduced because she's SATs are 91%, and that's while breathing 35% oxygen via a Venturi mask. She has dullness at the left lung base with some crackles that you can hear at that area through your stethoscope. Her pulse is elevated at 112, her blood pressure is low at 88/54, and a cap refill, I think I would suggest, is sort of a little bit prolonged at 3 seconds. She's alert, her glucose is 7.9, we know she's got type 2 diabetes, and pupils are equal in reacting to light. She has an elevated temperature at 38.2 degrees centigrade. And as we mentioned just a bit earlier, she has these crackles at left base, dullness to percussion, and when you do chest expansion, she has got reduced expansion as well. So what I'd like to do is come into the chat stream and ask you guys, see if you're awake this morning. Let's see how good your radiology is. So anybody want to come in on the chat stream and make any comments about her chest x-ray? Now, Richard, when you were at HIPS, I think we used to say to you, develop a system
Yeah.
for
Um,
reading
and
chest
I,
X-rays.
yeah, and I think when you're, early on in your career, definitely as a med student and as a foundation doctor, it's probably right to go through things sequentially like that, just so that you don't get into bad habits and start skipping things and then end up, missing important findings. Um, so yeah, so I mean, so first of all, whenever you look at a chest X-ray, first of all, you say about the demographics, so whose chest X-ray it is, when it was done, and then what type of a chest X-ray it is, so whether it's a PA or an AP film, and that gives clues towards how sick the patient is, because to do a PA film, so the X-rays coming from the anterior to the posterior, from the posterior to the anterior, you have to be stood up with your arms around the X-ray machine, so you can't be really unwell. Whereas an AP film can be done in the bed with the X-ray film sort of put in the bed behind the patient, and the X-rays coming from the front to the back. So it gives a clue to how sick the patient is. And then you go on to talk about things like penetration of the film, and rotation. I mean, there's a lot we can say about this, but you go through these initial things, and then you can do a sort of an A, B, C, D, E approach. So A as in looking at the air spaces, B as in looking at the bones, C looking at the costophrenic angles and at the cardiac shadow, and D looking at the diaphragm and below the diaphragm to see if there's air below the diaphragm, and then E for anything else, which could include, like, for example, you could see that there's surgical clips, or there's signs of a surgical emphysema, or other things that might be useful. So you can just go through in a sequence like that. Obviously, yeah, sometimes when you're on placement, people will ask you to give a spot diagnosis. They just want a spot diagnosis. But it's obviously certain educators will push you towards that, but I would sort of encourage, if possible, avoiding that way of looking at the X-rays.
I think I would say they're not educators if they do that. That's not a sign of an educator. I think Richard's right. There are a number of different systems. The ABCDE system, which links back into the AT approach for assessment, is quite a nice way of remembering it. I do think the important element is you have a system, and I don't think you lose that system, Richard. Even when you're a consultant radiologist, they still use the system. So they may become quicker at it, but it's the way of not missing anything. And I think you also need to develop a system for arterial blood gases. You can do the same for looking at electrolytes if you want to, although I think that's fairly simple to some extent. But ECG absolutely needs a system. And once you've developed that system, it begins to become second nature, and it means you don't miss anything. And I think that's the most important thing. And unless you practice it, you won't get better at it. I remember when I was a medical student, I actually bought a book of X-rays images, and I still have it somewhere, so I could look through X-ray images and learn how to read them. These days, of course, you've got things like Radiopedia, which you can go on to, which is a fantastic website resource for images. And I think also Life in the Fast Lane has lots of X-ray images as well now. Like it has some ECG images. I think it has some there. So we encourage you to practice reading these, because you will have to look at them. If you're the F1 on the medical admissions unit, and you send somebody for a chest X-ray at midnight, that's not going to get looked at by a radiologist till the next morning. So if you need to make a decision on treatment, you're going to have to interpret the chest X-ray yourself at, say, 2 o'clock in the morning, when the patient's film becomes available on the PACS system.
And I have to say that the radiologist reports, I often find that we get more out of it by looking at it ourselves, because sometimes obviously the radiologist doesn't really know. They obviously haven't examined the patient, haven't taken the history, and often the little vignette that's put on the request is very brief and not very helpful. And so, to be fair to them, their ability to make a diagnosis is limited. But I think quite often we get an X-ray report that says chest clear, but actually when we look at it, knowing what we know, we can see that it's not clear actually, and there's abnormalities that we can pick up. So yeah, I think you should always look at your own chest X-rays.
Well, yeah, absolutely. But if you're not looking at it, then why have you requested it?
Yeah.
Quite frankly, I think actually then there's actually what you've just described, of course, is a failure of the reporting physician. Sorry, not the reporting physician, the requesting physician. Because if you write so little in your request form that the radiologist can't adequately interpret it, that's not the radiologist's failure. That's a failure of the requesting clinician, in my view. Because all images, whether they be an ECG or a chest X-ray, they all depend on context. So if you don't write down enough, then it does make the radiologist's job more difficult. And I think actually that's a criticism of the requesting doctor, not of the radiologist. And of course, if you do have a spot and anything like that, you can then contact the radiologist, go back, sit down with them, go through the film, and explain the case better, and then they'll give you a great answer. So if you think a radiologist is missing stuff, it's probably more the case that you're not giving them enough information to allow them to interpret it. Right, guys, you've all got very quiet there on the chat stream. So does anybody want to look at this? We haven't said whether this is AP or PA, and the reason, of course, is why that's most important. It's not just because it tells you that the patient might be sick. It's because it's a PA film, which is where basically you stand with the X-ray imaging, whatever they call it. What do they call it these days? I used to call it a film because it was actually an X-ray film, just like a camera film. But of course, it's what do they call it? It's what do they call it?
I don't know, a plate or
Plate? Yeah. Anyway, because it receives the X-ray, and of course it's obviously sensitive to the X-rays driving at it. I'm trying to remember what they call it in a camera. It's the same as a camera. I'll come back to me. And if anybody knows the name, tell me. Basically, that's against your chest, and as Rich says, your arms are up and they're over around the top, moving your scapulars away from the chest, so you get a better view of the lung fields. And of course, the important thing is you then get a proper cardiac size, because your heart is at the front of the chest, which you will know from your anatomy, and that means that the chest film's right up against your chest and your heart's there, and then you get an accurate cardiac size. If you do it the other way around with the chest film at your back, then when you shoot it through, because the X-rays are actually slightly diverging as they travel, you can get an amplification of the heart size, because the heart now is at the front and the X-ray receiving thingy is at the back, and that means that the heart can look artificially enlarged. So if you have an AP film, you can't really interpret cardiac size. So no responses yet. Come on, guys. Anybody want to comment? Think about the clinical history. So we've described Francis as having crackles at the left base, dullness to percussion, and reduced chest expansion. So what I would do in a clinical terms is be thinking in my own mind, what am I expecting to find on a chest X-ray? So even before I request a chest X-ray, I'd be thinking in this case, what I'm expecting to find is possibly an infective process, or a consolidative process, or some fluid or something maybe, although that's less likely with those particular findings, at the left lower zone. So anybody come in? Are you there? Can you give us a shout out as to what you think might be the abnormality in this chest X-ray? And again, of course, remember that generally humans are symmetrical. Of course, your lung fields aren't completely symmetrical, because there are 3 lobes in this one and 2 lobes in this one, and the heart's slightly over to the left-hand side. But even allowing for that, you should be able to see the same density here as you see here. So I'm going to get my little pen across if I can. Try and show you what I mean then. Try and get you guys to all wake up. Yeah, there we go. Get my pen out. So what we're looking at, I think, in this sort of, oh, sorry guys, what's this? So in this sort of area, oh, not very good at drawing. No, I'm not very good at drawing, am I? This area kind of here next to the heart. I think what you can see is that area is much whiter, much denser than, say, this area across here. So this suggests that there's something making this bit of the lung more dense. Now, what's also interesting about it, I erase that now. My terrible drawing, I'm going to erase. If you look at this now, what you can see here, can you see that the heart border, the left-hand side of the heart border, is still visible down here most of the way. And this is a thing, I believe, that's called the silhouette sign. And what happens is, if you've got lung tissue that's maybe full of fluid, like consolidated lung, and it's at the same level as the heart, going backwards and forwards level, that is, then you would lose the heart border. So the fact that you can still see that heart border here suggests that this consolidative, more density process in the lung tissue is not at the same level anteroposteriorly as the heart. So that suggests it's perhaps posterior in the chest. So looking at that, taking the history into account with a fever, you have to think there's some kind of pneumonic process going on, and that it's probably in the left lower zone of that lung, which would fit with a left lower lobe pneumonia, if you think about your surface markings of the lobes of the lung. Does that make sense to everyone? Are you all there? Somebody come in and tell us that you can actually hear us and you're alive.
Yeah, that would be a shame if we've been muted this whole time.
Well, it's more that it makes us dispirited if we think we're just talking into the ether. So any of you there? Yeah. Alive and well. Samaya, thank you. Samaya, did you understand what we were just doing there with looking at the chest x-ray? I know this is not therapeutics, but as I say, you need to be able to make a diagnosis to be able to prescribe a drug. And as a physician, and Richard's a physician as well, I think I think it's important for us to teach you in a holistic way as well, so that we cover these sort of things. So the other thing is, if you actually also look at some areas here, I'll get my pen again. If you look around the rest, there's no other major abnormality. This is a well-penetrated film, and you've got, you can see the bronchi coming down quite satisfactorily here. Costophrenic angle, which is here, is clear. More difficult to see the one, perhaps, that is here, but that's because you've got a consolidative, dense process here. This is not a stomach bubble. This looks like a bit of colon that's flipped up and is, this is probably a splenic flexure at that point. It's just sitting under the diaphragm. That's quite acceptable and normal. So taking this into account with your clinical findings, well, I think this, if to me as a clinician would say to me, they've got a left lower zone pneumonia. If you want to go out on a limb, you could say left lower zone pneumonia. Sorry, left lower lobe pneumonia, taking into account the clinical features. Does that all make sense to everyone? I hope it does. Right. Okay, let's move on to the next slide. So I've answered my own question. I always do this. Okay, so we think this is a left lower lobe pneumonia. I suppose we could still say, what's the differential diagnosis, couldn't we actually, Richard? Because what we've described is actually a feature, a pneumonia, but there are different types of pneumonia. One,
Yeah, so they always say pneumonia is a radiological diagnosis,
Yep.
isn't it? And then, but there are other things that can cause, sorry, consolidation is a radiological diagnosis, and there are other things that can cause consolidation other than just infection. So you can get consolidation with autoimmune conditions. Cancer can cause consolidation by stopping drainage of sputum. So there are other things that can cause that.
Yeah. So I suppose the question is, does anybody want to come in with two alternative diagnoses? One which is like 99% the diagnosis, and another one that might be like 1% the diagnosis, based on the history we've had. Any ideas, guys? I know it's the beginning of year 3. Just want to see if you... I mean, what I'm thinking here, Richard, is this is most likely a community-acquired pneumonia. But of course, you should always take a decent history, just in case this is a hospital-acquired pneumonia.
Well, and I was wondering, I suppose you couldn't 100% rule out PE, could you? Because so when you have infarcted lung can look like consolidation, even though to have an area of infarcted lung that big would be very unusual. But given the fact you've got sort of a lady and she's tachycardic and hypoxic, and it's something to. I'm not, obviously, as we said, very much less likely than the community-acquired pneumonia, but some small possibility.
Very, 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 very small possibility. I think I think the reason I say that is because if you have, most often PEs have no findings on auscultation. So the fact you've got findings on auscultation either means it's a very old PE, in which case you'd have a much longer history and you'd have a clear precipitating event, or it's a combination of the two. This is pneumonia, 99.99999%, when you take the history combined with the X-ray findings. And actually, the majority of PEs, I'm sure you would agree, Richard, when you do a plain film, you see nothing.
Yeah, no. So I'm not in any way saying that this is high on the differentials, but if we are scraping the barrel to find other things to stop us getting tunnel vision, then it's something to be aware of. So normally a chest X-ray would be clear, but you can occasionally have chest X-ray findings with a PE.
But in reality, if you look at X-ray findings of a PE, what you might actually see after a PE, and this will be a few days afterwards, is maybe an area of consolidation or shadowing, not consolidation technically like that, which is a segmental area.
Yeah, a wedge infarction, and that's to do with the vascular blood supply of the lung. So if you had an infarct up at the apex of that triangle, then the area downstream would be infarcted. And so KD's just saying, is PE pulmonary emboli or pleural effusion? So it's a very good point where unfortunately we've slipped into saying things that we haven't defined, have we? But yeah, so it's pulmonary emboli.
Yes, pulmonary emboli, yeah, absolutely. Right.
So we don't abbreviate pleural effusion. Don't know why, but we never do.
Yes, it's an interesting concept of why do we abbreviate things. I mean, really, you shouldn't abbreviate, but I suppose we just fell into a very bad clinical habit there. Apologies, Katie. Right, let's look at the scoring system. So, from evidence-based medicine, there was a scoring system developed to try and judge whether or not you would be the mortality risk with a community-acquired pneumonia. But it was only validated, I think, up to age 75. So it's from like 18 to 75-year-olds. This is only valid. And it's based on, it's called CURB 65. The C is for new confusion. So if you already have confusion, then it has to be different or changed. So it's usually new confusion. U for urea greater than 7. R for respiratory rate greater than or equal to 30. B for blood pressure, and this is either a systolic blood pressure less than or equal to 90 or a diastolic blood pressure less than or equal to 60, and an age greater than 65. And if you tick any of these boxes, you get 1 point for each one. And what was found was if you've got a curb score of 0 to 1, your 30-day mortality is about 1.5%. It's not 0. You notice it's not 0. If you've got a curb score between 3 and 5, then your 30-day mortality is over 20%. So the curb score was designed to guide clinicians in making decisions about whether or not they could manage somebody with a community-acquired pneumonia, potentially at home with antibiotics, or whether they need to be admitted. And what I would say here, though, I think, Richard, I'm sure you would agree with this, is you can have a 20-year-old man or woman with a curb 65 score of 0 who can be profoundly hypoxic. But because they're young, they don't trigger any of these other numbers. But you clearly wouldn't send somebody who was oxygen requiring home. And if you notice in this curb score, there are no saturations, there's no oxygen levels. So I think the thing to realize is this is a guide. Guides are not absolute. You still have to use clinical common sense in addition to this. Would you agree with that, Richard? I think that applies to all scoring systems.
Yeah, definitely. And I think the other way that curb 65 is used is about choice of antibiotics.
Yeah,
Which I think,
but that's not evidence-based at all. There's no evidence base on using curb 65 for antibiotic choice. It's become a surrogate measure that has been extrapolated by microbiologists, but actually wasn't in the original papers. So what people do is they conflate the chance of going home with a low curb score. And I'm not saying that's wrong that they do it, but actually it's not evidence-based, to my knowledge. The only bit the curb is evidence-based on is this mortality and potential for ambulatory care versus hospital inpatient care. But Richard's absolutely right. Many microbiology departments and others you also use this to determine the level of antibiotic therapy. But that isn't. It's not. I don't think it's evidence-based. Do you think? Do you know anything?
I haven't looked into it,
Yeah.
but just from a practical point of view, that is another use of this score that we do see. Yeah.
But actually, you could just argue. Let's be honest. If you just looked at the clinical features and somebody who looks as sick as a parrot, you're going to give them a more broad-spectrum antibiotic. So it's interesting what you find in medicine. People had developed these scores. They do an evidence base. People forget the original papers, and then they effectively slightly misuse scoring systems. So I've seen people calculating this for people in their 80s, but technically it's not validated for anybody in their 80s. And it's certainly not validated for anybody who's a child, and there is no equivalent scoring system for children. Right. Okay. So it's just interesting to know how people then go on to use them. But if you think about it, if you're going to admit somebody with a curb of say 4, you're going to give them IV antibiotics, aren't you? So in some ways they're just extrapolating when they do that decision with the antibiotics. These are the blood results. So what you can try and do is calculate her curb 65 score. So would you like to go ahead and do that? She's 54, I think, Richard?
Yeah, 54.
54. So she's 54. And can you remind everybody what her blood pressure was? I'll write it down.
So her blood pressure was 88 over 54.
88 over 54.
And her respiratory rate was 26.
Respiratory rate 26 per minute. Okay. I think that gives us enough information for you to calculate her curb score. So go ahead on chat and calculate a curb score and stick it in for us, and let's see if we get the right numbers, the same numbers as each other. And I don't think she was confused, was she?
There's no mention of that.
No mention. So what do you reckon is the curb score for Francis?
So it looks like it's a 2. So as it says here, so there's probably going to admit this person, and in fact, as we said, another factor that's not in the curb score is that she's on 35% oxygen via a Venturi. So you're obviously going to admit her because there's no chance you can send her home.
And she's still, and technically she's still hypoxic on 35%. Yeah. But as I was saying, that's what I was trying to point out earlier on. The oxygen element isn't in the curb, so you still have to use common sense. So even if she came out as a curb of 1, the fact she's oxygen requiring means you need to admit her. So what we want to think about, and hopefully you guys, good question there from Samaya. What do you think about that, Richard? You're a younger doctor than me.
So as clinicians, will we need to memorize the normal ranges for the score system? So I think curb 65 is one of the most commonly used scoring systems. You see it used all the time. And so I think you will just memorize that one. But I don't think there's any particular need to memorize it. I wouldn't encourage it necessarily to be memorized, but I think you will just because you use it regularly. The other one that we use a lot is a Wells score for probability of PE, and then there's a separate Wells score for DVT as well, which we do use a lot. But then there are a lot of other scoring systems that can be used, and definitely, people are not memorizing them. And you'll find often that the clerking documents for acute medical admissions will have a back page with a number of the commonly used scoring systems on there, and that can be helpful. So as you're doing the clerking, then you can add a bit more detail to your diagnosis. So you can say community-acquired pneumonia, curb, or whatever, or well score this or whatever. So it can just be a little thing to help. But
yeah, the answer to curb 65 is yes, you need to memorize it. For curb 65, there are some questions in the National Question Bank and in the PSA National Question Bank that if you do not know the curb 65 score, you could potentially pick the wrong answer. So it is, as Richard said, probably one of the commonest known scoring systems. So I think by the time you get to year 5, you need to have memorized curb 65.
But are we fair to say that's the only one you need to memorize? You wouldn't be expected to memorize Wells score, would you?
No, but there are questions. I know there are questions in the National Question Bank for the medical licensing assessment that if you were not able from the clinical history to apply a Wells score, a curb 65, it helps you to answer the question. And I think, to be fair, it's not difficult to memorize. It's why we put it in here. It's only got 5 points, and the very name 65 tells you one of them. From that point of view, so it does allow you to assess. Whereas others, to be honest, in clinical practice, what I did was I used an app on my phone called MedCalc, and in MedCalc it gives you a number of medical calculators which you can use, and there are a number of these apps. That's not the only one. And you can also, it has all the scoring systems. So things like CHADS VASC, the CHADS 2 VASC 2 score. I never memorized that one. I know some people did, but I always use the app, to be honest. So I think in clinical practice, the general principle is you can use a decision aid like an app, or as Richard says, the back of a guideline might have them on it. But for your purposes, I think you should memorize Curb 65. I think it helps you answer some questions in exams. It's just a, community acquired pneumonia is a very common diagnosis. So what we'd like you to do is use your BNF, and I'd like you, on the basis of a Curb 2, to try and decide on an antibiotic choice for Francis. So I'm going to bring up my BNF as well, and I'm going to try and look for it. So you go into your BNF for a second and have a look and see what you can find. Right, so what I'm going to show you here are little things about the BNF. So I've typed in community-acquired pneumonia into the search bar in the BNF, and it gets me absolutely nowhere. You see that? It pulls up something called Keftobiprole, which I have no idea what it is. So that doesn't work. So what about trying something easier? Chest infection. Oh, and that brings up Dornase alpha, which is really a drug used in cystic fibrosis. So that's not helping either. So one of the things to learn over the next 3 years is how best to search within the BNF. So it didn't like community-acquired pneumonia, which is a very specific term. It didn't like a very non-specific term like chest infection. So let's try respiratory. Now I seem to do better here. It's now bringing up a variety of options. And at the bottom there, you can see respiratory system infections, antibacterial therapy. So one of the things you need to learn as you move through medical school now is how to use the BNF, because it's one of your most important tools. So we can click on that, and then we can go down and we look for pneumonia community acquired. And now it will tell us what to do. It will allow us, if we want to, you can link out to a nice guideline. But that's been added subsequent to COVID-19. But you can go down and read through. You can go about reassessment, and then you've got choice. And though it isn't, as Richard was pointing out, people use it for, and even the BNF is now saying, use the Curb 65 to judge clinical severity. Add this to the idea of what's the suspected microorganism, and then you can decide on the antibiotic. If you're in GP land and you haven't got access to a urea, you can use CRB 65. So it's basically Curb 65 without the urea. So that's why that's SCURB. SERB. Is that SERB 65 versus Curb 65? There you go. So have a look at that section and come in on the chat stream and tell us which antibiotic you think. I'm going to come off that for a second so I don't give you a hint. But do come in and make a suggestion on the antibiotic. And it all hinges on whether you think the BNF uses a criteria of low, moderate, and high severity for community-acquired pneumonia, which I think links in, partly to the Curb score, doesn't it, Richard, of 0 to 1 for low severity, 2 for moderate, and 3 to 5 for high severity. Would you agree with that?
Yeah, I think so.
So come in on the chat stream and see if you can suggest an antibiotic to us. So you need to think about other elements to do with Francis. And I think if I'm just going to jump back. Amoxicillin, yeah, I was going to jump back and look at a penicillin allergy, but I've actually noticed I've got it on the slide. So there we are. So Mia and Tanya are saying amoxicillin. Yeah.
So would you use amoxicillin by itself?
You asking me or are you asking them?
Sorry, to the chat.
I think, well, there is an answer to that. They haven't said anything else, Richard. And I think the reason why they haven't said anything else because in the BNF it doesn't tell you to.
Oh, fair enough.
There you go. So in low severity, it's amoxicillin. But what it does do in moderate severity is it says here, if you suspect atypical pathogens. So does anybody know when the BNF says atypical pathogen, what might we be thinking about? The most common causes, remember, of community-acquired pneumonia is going to be Streptococcus pneumoniae. Second most common is going to be Haemophilus influenzae. So respiratory physicians, they may not know this, Richard, which is why I'm just asking. Do you know what atypical pathogens, when the BNF says atypical pathogens, does anybody know what that means? If you don't, say no, and we'll talk about it.
Yeah, so we're not talking about viral pathogens because obviously it doesn't matter what antibiotic you choose, that's not going to treat a viral infection.
So maybe not. What would you class as atypical, Richard?
So they're bacteria with atypical sort of cell walls or that wouldn't respond to beta-lactam type antibiotic. So we're talking about things like Legionella, Mycoplasma, and then sort of rarer things like chlamydia, and there's a number of different other organisms.
Yeah.
So it's to cover those organisms, which.
And what Richard was asking, why he was asking you about, is it alone? If you did suspect an atypical pathogen, maybe the picture on the X-ray was different to the one we saw, which is typical of a lobar pneumonia, and it was maybe upper zone or something, or different kind of shadowing pattern. You might suspect an atypical organism, or if they'd come from a hotel where other people have been brought in with pneumonias and you thought it might be Legionella, then you would usually add clarithromycin, to be honest. And that will give you combination in that scenario. But for a straightforward CURB2 pneumonia, generally you would go with amoxicillin, according to the BNF. The reason why I say according to the BNF is every region in the UK will have subtly different antibiotic recommendations based on local resistance patterns to antibiotics. So you could go and work in Plymouth and they might have a different antibiotic choice, and they might always give dual antibiotic therapy for a CURB2 pneumonia, whereas in Hull we might just generally use single antibiotic in Hull, for instance. So wherever you end up working in your foundation jobs, always follow the local antibiotic guidelines. If you have a high severity, then it's absolutely, you go and go to co-amoxiclav. And as you know what co-amoxiclav is, remember we did this co-amoxiclav is a combination drug. So it's a combination of amoxicillin, which is the amoxy bit, and then it's got a clavulanic acid bit. That's where the name comes from. And the general dosage would be 125 milligrams. So 500 is the amoxicillin and 125 milligrams is the clavulanic acid. And the clavulanic acid there is a beta-lactamase inhibitor. So it inhibits the beta-lactamase of the bacteria, which would render it resistant to amoxicillin. So by blocking the beta-lactam enzyme, it makes the bacteria sensitive again to amoxicillin. So by making amoxicillin into co-amoxiclav, you make it a broader spectrum antibiotic, which is theoretically more potent. And as you notice also on the, oh, and you couldn't see that, could you? I'm drawing on it, and you couldn't see it. So that was my diagram there, to show the amoxi bit there with the clav bit, and these are the respective doses of the two different drugs making up the combination drug, and this makes it broader spectrum. And what that then means is when you get to a high severity pneumonia, you'll either, usually, I have to be honest, generally it'll be a high scoring curve, will get intravenous antibiotics. So you might well be an intravenous coamoxiclav, and then sometimes oral clarithromycin, Richard, isn't it?
Yeah, because clarithromycin has such a good oral bioavailability that there's, the only situation that you need to give it IV really is if someone is unable to swallow or their gut is not working for some reason.
Yes, it's also very irritant to veins as well. So what you then end up with, so you obviously you're broadening out the antibiotic profile by going with a broader spectrum penicillin and always adding in clarithromycin as a macrolide to cover for those atypical bacteria. Right. Okay, so this is what you get. This is an example of the local Hull guidelines from, I think, a couple of years ago. I don't know if it's changed any at all.
I was just looking at the IV clarithromycin there.
Yeah, I know. If IV needed. It says if IV needed, and that could be because the patient's vomiting. Then you would have to give IV clarithromycin if they were vomiting. But this is an example of a local guideline, which, as you can see, slightly varies from the one in the BNF. Although the community-acquired treatment, again, is oral amoxicillin. But if IV needed, then you just convert IV. Then again, you may have somebody with a curve 65 pneumonia of 1, and it could even be that they're nil by mouth for some other reason, in which case, you might have to give IV. That's not because of the severity, but it's maybe another reason why they have to have an IV. So what it's basically showing is how local guidelines can vary from national guidelines, which from our perspective, guys, makes it really difficult to write antibiotic questions in exams. Particularly, say, which antibiotic would you use in an exam is difficult. In the PSA exam, which you do in year 5, it's easier because, of course, you have access to the BNF in the examination. So I've asked this question, what are these antibiotics? Obviously, there's a penicillin, there's amoxicillin, because the name tells it is psyllin. Doxycycline is a tetracycline. The cycline bit tells you what it is. And clarithromycin, the mycin bit tells you it's a macrolide. So there are hints here. Okay, one of the things that sometimes gets asked, there is a cross-reactivity between penicillin allergy and cephalosporins, isn't there, Richard?
Yeah. And it depends on the generation of the cephalosporin. So there's first, second, and third generation, and each subsequent generation has less cross-reactivity. So the first generation cephalosporins had I think I'm right in saying about a 10% cross-reactivity with penicillins, and then that drops off. So by the time you get to a sort of third generation where it's very low numbers, but still something to be aware of. So it depends what the allergy is. So that's why it's super important when you take an allergy history to not just get the thing that they're allergic to, but what the allergy was. So if it was just a rash, then a cephalosporin would be perfectly acceptable choice. But if it was anaphylaxis, then that's probably not going to be the right choice, and you would choose something that's not going to cross-react at all. Something like ertapenem or various other things. But again, if you're unsure, you can discuss it with the microbiologist.
So I just put this slide in, not for anybody to memorize, but just to point out the most common causes in the United Kingdom of community-acquired pneumonia as being streptococcus pneumonia and Haemophilus influenzae, as I said, and then the rest go down to much smaller numbers. The profiles change, obviously, when you end up getting a pneumonia in hospital. And if you're in an intensive care unit on a ventilator, your microbiological profile subsequently changes. So the antibiotic choices between a hospital and a community-acquired pneumonia are different. But don't worry too much about this at this stage. But you can see the atypical organisms become much more common in a hospital-acquired pneumonia. That's the mycoplasma and chlamydia particularly. So what I'm going to do now is, because we've been talking in principle about antibiotics, is switch over and we're going to think about what is antibiotic stewardship. This is a term that was developed a few years ago because I'm sure you've read in the media that antibiotics are at risk of losing their effectiveness, and in fact there are some forms of sexually transmitted diseases in places like Southeast Asia where in fact they literally are not responsive to any antibiotic. And in fact there was an outbreak in Leeds only I think about 6-7 years ago, wasn't there, Richard, of multi-drug resistant gonorrhea in Leeds. So there is a real concern that because we are overusing antibiotics, inappropriately using antibiotics as a community, that in fact we'll lose access to those antibiotics and go back to the pre-antibiotic era, where many operations which we do today would be therefore unachievable because you need antibiotics to allow that operation to be successful. So we now need to be very careful with our use of antibiotics. So antimicrobial stewardship is all around preventing the development of antibiotic resistance. And of course, antibiotic resistance develops a whole range of complex ways, but the fundamental way is and bacteria which survive an antibiotic and go on to become the predominant new strain will inherently be resistant to the antibiotic they were exposed to. And an antibiotic effectively, under Darwinian principles, applies an evolutionary pressure to that microbes species. So what I'm going to actually do is I'm going to show you a video in a couple of minutes, which I think encapsulates it very nice. I'm hoping it'll run without any problems. But what we've got to think is, in principle, when using antibiotics, you prescribe by the shortest and effective route. You use the most appropriate dose. So that's not necessarily the lowest dose, it's the most appropriate dose that's correct for that indication. And you choose the correct route of administration. So in other words, don't continue with IV antibiotics for longer than necessary. And it is an important element that, and we as doctors, I think it's fair to say, Rich, isn't it? We as doctors, we always want to do the best for our patients. If you didn't, why are you a doctor? And therefore, when you see somebody coming in who looks sick, we want to throw the most effective treatment at them. So the inherent thing is to give intravenous antibiotics, even though in fact that patient might have a curb zero pneumonia. So, but if you give every curb zero pneumonia intravenous coamoxiclav, very, very soon you're not going to have coamoxiclav to treat the very bad pneumonias where people die. So it is very important that we follow the rules of antibiotic stewardship. And these are the British Thoracic Society guidelines, recommendations around community-acquired pneumonia. And these are common to most antibiotic use for any other indication. You need to be certain of your diagnosis. You need to start antibiotics early. If you're going to give them early, and that's also part of the sepsis 6 guidelines, which we'll come across as we move forward in your training. You should stop antibiotics if they're not indicated. So if you start one and then realize it's a viral infection, you don't have to finish the course, just stop the antibiotic. You need to document your reason for why you gave an antibiotic in the case notes, and very clearly. If you give somebody IV antibiotics, you need to review it every 24 hours and discontinue it as soon as possible. And you should always narrow down the spectrum of your antibiotic therapy when you know what the actual pathogen causing it is. So this is called antibiotic streamlining. So that means you may start with coamoxiclav because you're not quite sure what's causing the infection. But as soon as you realize it's strep pneumoniae, which you know will be sensitive to plain amoxicillin, then stop the coamoxiclav and just give them amoxicillin. So go down, narrow it down to the most appropriate antibiotic. That way you don't affect lots of other bacteria which could develop antimicrobial resistance. And you should have a specified stop date. So for community-acquired pneumonia, routinely that would be 5 days duration of treatment. For some UTIs, it's one single dose, or maybe only 3 days. So I'm going to see if I can get this to play, and we'll all watch it together for a minute. I'm hoping. Can you guys hear that okay?
Hi there. Did you know that 70 years ago, penicillin saved countless lives in World War II? Fast forward to the 21st century, and the chief doctor in the UK calls for antimicrobial resistance to be put on the National Risk Register and be taken seriously. And the US government describes antimicrobial resistance as one of our most serious health threats. In Canada, outbreaks of superbugs frequently make headlines because they kill patients. Antimicrobial resistance isn't a new phenomenon. All germs have the ability to develop resistance. But the more drug exposure there is, the faster resistance develops in people, animals, and agriculture. We now face infections that are resistant to many, if not all, of our available drugs, and there is very little to look forward to in the antibiotic development pipeline. Since 2010, only 3 new antimicrobials have been approved for use in Canada. This means that we must manage these precious resources more wisely, like preserving clean drinking water or halting global warming. Inappropriate or unnecessary use of antimicrobials is often cited as up to 50%. Misuse of antimicrobials is risky to patients. It can increase mortality, time spent in hospital, and lead to collateral damage, such as a new infection with another bug, like C. difficile, a germ that causes diarrhea in most but may cause serious or fatal infection in others. Using antimicrobials appropriately will not only help preserve our antibiotics, but will also improve patient outcomes and patient safety. Everyone wants to do the best thing for their patient. Sometimes that feels like wanting to give the strongest, broadest spectrum antibiotic. But we need to ask, is that really the best thing, not just for this patient, but the patients in the global community? We need to carefully think about why we are giving an antibiotic, what drug we choose, and how we are using it, dose and duration of therapy. We are falling behind the curve with the prevalence of multi-drug resistant organisms and the lack of new and innovative antimicrobials. Antimicrobial stewardship is just one facet in the efforts to improve outcomes among patients with infections and reduce the incidence of resistance. Everyone plays an important role as good antimicrobial stewards.
Right, I hope you found that little video useful. I thought it was a great video, to be honest, for summarizing the situation with antimicrobial resistance. So let's look at these broad principles of antimicrobial prescribing. The things I want you to think about here are, is it the right antibiotic for the right patient at the right time? And one of the key things there in clinical practice is, have we obtained appropriate cultures before commencing the antibiotic? Are we using the right dose? And that can mean, are we using too low a dose? Are we using too high a dose? And what about the patient's renal and liver function? Are we using the right route? Could we use oral or using IV. Oral is less likely to develop problems than IV is. And we need to think about least harm overall. So we use narrow spectrum antibiotics when we can, minimize duration of treatment, and frankly, choose antibiotics with the least amount of side effects. So don't go for the newest, most toxic antibiotic because you think it's best for your patient, when you can use an old-fashioned antibiotic which we understand has got limited side effects.
And Samaya's just put, so just confirm, when you're waiting for a culture to come back, do you give, there's always a heart over the corner of the comments, or do you give co-amoxiclav or slash amoxicillin?
Well, the answer to that is very simple. How long, Samaya, do you think it takes to get cultures back? So you remember when, I don't know if any of you have seen what happens in the microbiology lab, but you send something like sputum off, they're going to, they'll maybe do a smear of it, look at it under the microscope, but what they'll do is they will actually plate it out on Petri dishes, and then it will be put in an incubator to grow, and that would probably grow for about 24 hours, and then they will look at the colonies they get on the agar plate, and then from that they will then also they might subplate that out then onto another agar plate which has got antibiotic discs on it. So they plate it out over the whole agar plate, and it's got antibiotic discs that release antibiotic, and they'll see which antibiotic the microbe is resistant to. So you may not get an initial microbiology result for 24 to 48 hours. You can't wait that long. So if you've decided it's community-acquired pneumonia, as you would do for any other infection, you take the culture and you send that off. You make sure it's sent, but you start the antibiotic. And the idea these days is, because of the Sepsis 6 guidelines, that you should start the antibiotics within an hour of initial assessment. And that's from arrival. It's not from when you finish clocking them, which might take an hour. It's from when you start. And that's the guideline, is to try and get the antibiotics in within an hour. So you have to make a presumptive diagnosis and go, and that's why you may start with a slightly broader spectrum antibiotic until you have more information. But when you get the microbiology back, it says, yeah, this is strep pneumoniae and it's highly sensitive to amoxicillin, in which case if they were on co-amoxiclav, you could stop the co-amoxiclav and change it to just plain amoxicillin. Does that make sense? Because again, I think one of the things I find medical students, that they don't understand the timing of how long it takes to get tests done. Is that a fair comment, Richard? Because I think it's something I didn't understand as a medical student.
Yeah, I think it's one of those parts that's easy to not understand.
Yeah, I had a slight advantage. I did an integrated degree in pathology, so I spent time in microbiology labs, blood transfusion labs, histopath labs, hematology labs as part of my integrated degree. So by the time I got to year 3 in my course, I did understand how labs work, but I think a lot of people don't necessarily understand how long it takes for things to happen. Okay. So what kind of infections do you get? Do you guys know any multi-drug resistant infections that have arisen out of the inappropriate use of antibiotics? I think the guy in in that little video did give one. I think he said C. difficile, didn't he? Do you know of any others? Anybody know of any other? While you're thinking about that, I'm going to have a slurp of my cold tea. Nobody got any other ideas? Let's have a look. I just put these things down and look at these while we're waiting for you to come in with any particular ideas. Some key points. Sepsis 6, Richard. This is something we drill now into all the junior doctors, isn't it? Sepsis 6 principles.
Yeah. So the idea is you need to get, we can go through it, but these 6 key investigations or treatments done within 1 hour.
So it's 3 in and 3 out is the way to remember it, I think, isn't it?
Hmm.
So what are your 3 ins? So things you put into the patient.
Yeah. So basically, so you give broad spectrum antibiotics. So this is for sepsis. This is not just for any infection. And but for sepsis, so when someone's acutely unwell with what you assume is sort of a systemic infection, then so then you give a broad spectrum antibiotic, IV fluids, and high flow oxygen, and then you take
Three things out.
so you take urine, which is put in a catheter. Basically, it's not so much that you're taking the urine for culture necessarily, although that might be necessary. And then you take a lactate measurement, and you take blood cultures.
Yeah. So there you go. So before you give the antibiotic, what you do is you take your blood cultures. You obviously send other bloods off as well. You do a venous blood gas from which you can get a lactate estimation on the blood gas machine. And you ask the nurse to prep a trolley so you can insert a urethral catheter to monitor urine output.
I have to say, Prof, that you've it's nice to think that a nurse might be able to prep a trolley for you for a catheter, but I'm afraid.
I might be showing my age. Okay, you will prep the trolley. Mind you, they would do it for me when I was on AMU, but I suppose I was a consultant.
I think that's right.
Yeah, I suppose so. Yeah. The only thing, I think the last thing you do is the catheter, because it takes time to put one in and to get it all ready. But the main things you do, get your blood cultures off, give your antibiotics after the blood cultures, get your lactate measured, start your IV fluid through a cannula, usually a big one, and give a fluid challenge, and start oxygen, unless there's a contraindication. And then you just got to think about these. We've spoken about them all durations. So CD's coming with C. diff. The other ones you've got to think about is MRSA, which seems to be less common now than it used to be, partly because we've got better with our antibiotic use. So methicillin resistant Staphylococcus aureus, that was a real nasty a couple of decades ago. The other one to think about now is ESBL, so extended spectrum beta lactamase producing bacteria, usually gram negatives, which basically there are virtually no antibiotics left that can treat them. And there will be others coming along which are resistant. And the trouble with these are they're very difficult to treat, and you end up using incredibly toxic antibiotics, which are not good. So we want those things to not develop in the future. And the best way to do that is judicious and appropriate antibiotic use. So let's move on, because we have only got 20 minutes left. This is case 2, which is Mary Percival. And she's come in with shortness of breath and a right-sided pleuritic chest pain after returning from holiday in Turkey. And this is her chest x-ray. As Richard had pointed out earlier on, this is AP sitting, and what that tells you is she's poorly. So they've not managed to get her to stand up and go to the x-ray department. She's probably had a portable film done in the bed. They bring the portable x-ray machine into the ward. They put the x-ray plate, I'll call it a plate rather than a film, behind her, and they've kind of done their best to prop her up, and shot the x-rays through the front of her chest back to the back where the plate is, which means that her heart size could be exaggerated, because she looks like she's got cardiomegaly there, because that heart size is more than 50% of the transthoracic diameter, and therefore it looks like she's got a large heart, but actually because it's AP you can't interpret it. But I would hope that you're all seeing that there's this more diffuse shadowing, particularly on the right lung, and also some there next to the heart as well. So this doesn't look good. This is more extensive than it was in Francis. What would be your differential diagnosis? Come in with some ideas what you think might be wrong with Mary, based on the history you've got there and the x-ray features that you can see. I haven't given you much other information, but if you just think about it, this is a consolidative type sort of airspace shadowing. What could this be? I've not given you a temperature, so I do expect a few differentials. Do you think she went to get her turkey teeth done? Right.
Yeah, apparently, just as a random aside, they're saying now anyone who gets dental procedures, surgical procedures, tattoos, anywhere abroad now, they're asking to have a home Hep C test. Because I think there's quite a few people coming home with hepatitis C infection and then quietly causing liver disease.
Yeah, so Mayor's come in and said if she did get her teeth done, maybe it's staph pneumonia. Good one here. Yeah, I don't think she had the teeth done.
So actually, sorry, just to pull that apart a little bit.
Yeah.
What do you staph pneumonia? So I think you're either saying strep pneumonia, streptococcus, or are you saying
Staphylococcal.
or as in Staphylococcus aureus pneumonia? Okay, that's fine if that's what you meant. It's just to point out that obviously that's not a bacteria in itself, but yeah, if that's what you meant, that's fine.
Yeah. And Ellie said pulmonary embolism. Again, the features we said before is you generally don't see much on a plain film with a pulmonary embolus. Although, because she's had a flight, I absolutely agree you should maybe throw in pulmonary emboli. And of course, pulmonary emboli is often what we would call a red flag diagnosis. So often if it's a breathless patient, it's reasonable to throw in pulmonary embolus as one of your differentials because it's a red flag. But I think with these particular film, I would put pulmonary emboli near the top of my list. I'd put it down near the bottom. KD's saying TB. What do you think of TB, Richard?
So I think the important thing with TB to know is that it very rarely gives an acute pneumonia. It's more of a sort of a chronic, indolent sort of disease that causes weight loss and night sweats over weeks and months, and it presents like that, rather than like an acute pneumonia like this. And if it did, and the pneumonia that you classically see with TB is upper lobe, because the upper lobes are more highly aerated, and that's where TB likes to live.
Yeah, two types of bacteria that you often associate with upper lobe involvement. One is TB, and the other one is Klebsiella. It likes the upper lobes as well. Yeah. Okay. Let's have a look and see what we said as a. We were leaning because this is more diffuse. She's more unwell. This, if you saw it, unlike the one we saw before with Francis, which was more circumscribed, one side of the chest looked like it was isolated to one lobe or even one part of a lobe. That looked like a lobar pneumonia. This one is more diffuse. It's affecting both sides of the chest. You can see there's some consolidated process over here. It's going up into the upper zone here. It's far more diffuse. This is the feature that's much more typical of what we were speaking about before, which is an atypical pneumonia, or a pneumonia caused by an atypical organism. And the atypical organisms, as we were chatting about before, are usually, there are more than these, but these are the common ones: Mycoplasma pneumoniae, Chlamydophila pneumoniae, and Legionella pneumophilia. Oh, they make these names difficult too. Basically, Mycoplasma, Chlamydia, and Legionella. That's easier to say. But you can also get a similar feature with some viral and fungal pathogens as well. And here's a nice colour electron micrograph. Somebody's coloured these in, haven't they, using Photoshop, of Legionella pneumoniae bacteria. So if you saw that picture, that's where you're going to be thinking about using an additional antibiotic like clarithromycin. So if we again look here, I don't expect you to memorize this. Please don't memorize it. I'm just using it to kind of show you the difference in antibiotic therapy. Strep pneumoniae is generally very sensitive to penicillins, and you can use these relatively old-fashioned penicillins very effectively. Mycoplasma, on the other hand, is much more sensitive to macrolides and is quite resistant to penicillins. So you can either use a macrolide like clarithromycin, or you can use a tetracycline like doxycycline. And these are both pretty common go-tos. We're much less likely these days to use a fluoroquinolone. That's things like ciprofloxacin, because there's quite a lot of multi-drug resistance to some of the fluoroquinolones now, partly because they were overused in the Far East. And Legionella, you may well have to use a fluoroquinolone or clarithromycin. And where we go, and we spoke, didn't we, there, Samaya, about Staph aureus. Staph aureus pneumonia is actually not very common. And if it's non-MRSA staph, then you can use flucloxacillin. Potentially also adding in rifampicin. Interestingly, rifampicin is normally used for tuberculosis. If it's MRSA-based staph, then you would be using vancomycin or something like linezolid or teicoplanin. But what it's really saying here, I think, is that if you think this is an atypical pneumonia, you need to be thinking about adding in something like a macrolide. So here's an example of a very localized upper lobe consolidation. You can see here, 20-year-old woman called Sophie came to a GP with a month of cough, fever, and weight loss. So I think Richard's given you the diagnosis in his previous description. Anybody want to suggest what this might be? So she's got weight loss, she's got a cough, it's a prolonged history. What might this be? So this could be TB. Yeah, this is much more likely to be TB. And don't doubt, TB is still around. I do believe a couple of years ago you were far more likely to catch TB in London than you were in parts of India. In fact, there was an outbreak a few years ago on Hessel Road in Hull, in a pub, of TB. A lot of people in the pub got TB. Somebody was obviously sitting there drinking their beer and coughing over everybody, spreading tuberculosis. So we think that's probably tuberculosis. So one thing I wanted to do was very briefly touch on tuberculosis and the principles behind TB pharmacotherapy. The key thing about TB is you're going to have to give, this is a much slower growing bacteria. It's more resistant to antibiotic therapy to some extent, but it's got one feature, and that is that it's very likely to develop antimicrobial resistance. So in treating pulmonary TB, and I'm not an expert in this, but the chest physicians do it all the time, you've got to think about multi-drug therapies. And the four commonest drugs used in treating TB currently in the UK, and this is standard TB, because there are unfortunately also a form of TB called multi-drug resistant TB. And again, I think London was one of the most common places you could catch multi-drug resistant TB in recent times. And that's because people have only had partially treated TB, and it's allowed their particular strain of TB to become resistant to many of these drugs because they've not had appropriate therapy or not continued their therapy. So we usually give up to 4 drug agents, antimicrobial agents, at the one time. Why might we give them all at the one time? What's the advantage to that? Can you think of a reason on the chat stream? I just threw a little picture in there because I think it's interesting. If you take rifampicin, you get orange-coloured urine.
Yeah, and not just urine, actually, any bodily secretion.
Yes, your tears are orange as well, aren't they?
Yeah.
So in our community acquired pneumonia from strep pneumoniae, we just use amoxicillin. Yeah. So the way I like to think about it, and this is, I mean, again, I'm not a microbiologist, but the way I think about it is, say you're using rifampicin, which is a rifamycin, and you just gave that alone. There might be 1 in 100 bacteria of the TB bacteria, which is resistant to rifampicin. That one bacteria will then become the predominant strain in that individual's body, and it's now resistant to of course it's resistant to rifampicin. If you then added in isoniazid, having stopped the rifampicin, then you might find again that maybe 2 of 100 of those rifampicin resistant TB might be not be sensitive to isoniazid. And basically what it means is if you layer them all on top, you end up in a situation where it's extremely unlikely that any of the TB bacteria will be resistant to all of them, or be able, if they started to develop resistance to the rifampicin, they would still be killed by the isoniazid. And this is to prevent the development of drug-resistant tuberculosis. Other drugs that sometimes used in tuberculosis therapy are streptomycin and azithromycin, which again, it's another macrolide. There are some interesting things about these drug therapies, and that is that you generally give it in phases. You have a kind of an intensive phase, and then you have a continuation phase. But virtually everybody needs 6 months of treatment because it takes a long time to eradicate the bacteria. And of course, remember, TB isn't just necessarily in the chest. TB is a big mimic. It's a bit like syphilis. It can manifest in many different ways. I mean, have you ever seen TB in the kidney? You must have done, Richard.
I've never seen TB in the kidney, no.
But it is another common area, isn't it?
You can get, so granulomas in the kidney. If you get that on a biopsy, you need to think about TB. But one that you might see, especially if you work on, if you have placement on an ITU, is tuberculous meningitis, which is really nasty. And those patients, if they survive, often need sort of a year's worth of treatment afterwards. But basically, it can infect bone, so that's called Pott's disease, and it can affect literally anywhere. The retroperitoneum, you get retroperitoneal fibrosis. There's all sorts of it can do almost anything, can't it? It's
Indeed,
unusual bug.
Yeah. So the intensive phase is usually made up of these 4 drugs for 2 months, and then after that intensive phase, you can sometimes drop down to having just 2 drugs. And the reason for that is that the isoniazid and rifampicin are generally well tolerated, whereas particularly the ethambutol is associated with the risk of side effects in your eye, so it has to be carefully monitored. So just to cover these things, the rifamycins like rifampicin, these are interesting to pharmacologists because they have many, many drug interactions, because they induce cytochrome P450 enzymes. I'm just going to move me a little bit. Particularly CYP2C9 and CYP3A4. So CYP3A4 is responsible for about 50% of drug-drug interactions. CYP2C9 covers things like statins. So basically what it means is that these will induce these enzymes, and it will mean that other drugs are more rapidly metabolized and will lose their effect. They also can cause liver damage. Now, I included this chart here, which actually I do think is worth remembering to some extent, because if you can remember these, it helps you cover lots of the drug-drug interactions you'll come across in the future, because these are inhibitors and inducers of CYP3A4, that particular cytochrome P450. So if you look like inhibitors, these are antiretroviral agents, often used in HIV. And then you've got things like clarithromycin and erythromycin. These are the macrolides. And then you've got antifungal agents, the conazoles here. And then you've got the non-dihydropyridine calcium channel blockers down at the bottom. And basically these inhibit CYP3A4. So if you have a drug that's metabolized by CYP3A4, then that drug will become more available and you can get toxicity. And then you have inducers of CYP3A4, which is usually anticonvulsant drugs, and then these rifamycin antibiotics. And what that means is these will effectively, it's a bit like toning up the liver. It's going to metabolize those drugs more quickly. And that means that any drug that was in a therapeutic level it may drop below the therapeutic level when you're also taking these drugs alongside it. And that also applies to St. John's wort here, and also some of the other antiviral agents down at the bottom.
Yeah, and I think as a general rule of thumb, it's pretty fair enough to say that the inhibitors of the P450 enzymes usually act quite rapidly to inhibit the enzyme and raise the levels of different drugs, whereas inducers take a bit more time to drop the level. So you find, if you start an inhibitor of P450 like clarithromycin, it very rapidly can cause dangerous drug interactions. Like it will put warfarin levels through the roof. It will put statin, if they're still on a statin, it will raise those levels and potentially cause rhabdomyolysis. So it can do it very rapidly, whereas the inducers take a bit more time. It doesn't mean that you ignore that fact, but it's just something to be aware of.
Because basically they're going to have to the liver has to make more enzyme. That's why it takes time, isn't it?
Mm.
But what's interesting, if you look at these anticonvulsants, and we're a bit off topic here, but like carbamazepine, when you start carbamazepine, you have to gradually increase the dose. One of the reasons you have to gradually increase the dose, because it induces the enzymes, it also actually effectively reduces its own effectiveness. So that's one of the reasons why the dose has to be titrated up over time. Isoniazid is interesting, and it works basically it works because needing a cup of coffee. So it's a prodrug, and basically it only gets activated within the mycobacteria. Hence why it works in the mycobacteria, not against us. And it alongside rifampicin is one of the essential drugs for the treatment of tuberculosis. The downsides of it is that it can be hepatotoxic and it can cause a peripheral neuropathy. So that's important. And usually, because it's one of these essential drugs, it's often dispensed as a combination drug with rifampicin. One of the ones I remember from junior, it was called Refiner, because rifampicin at the beginning and Ina for isoniazid. So
Yeah,
it's usually given as combination.
and I think and the infectious disease team are always really keen to give these combination tablets, because a lot of the patients who suffer with TB are people who sort of traditionally don't really engage with healthcare, and so trying to make the treatment regimen as easy to follow as possible is really important.
Absolutely, yeah. Because actually, if they stop it prematurely or they don't take the tablets well enough, they're going to end up with multi-drug resistant TB. Pyrazinamide. Maybe. So this one cannot be used ever alone, because you very rapidly, the mycobacteria can develop resistance to it. So it's very much an add-on once you're already on rifampicin and isoniazid. Its main issues are that it can cause hepatotoxicity, but it's good because it crosses the blood-brain barrier. So if there's any mycobacteria in the brain or in the meninges, then this can get to them, and it's very good for treating that tuberculous meningitis that Richard mentioned. Ethambutol is pretty toxic, and that's why it's generally only used in the initial intensive treatment phase, because it can result in an optic neuritis, and you can get some red-green initial colour blindness and then gradually reduce visual acuity. And this is a fundal photograph trying to show you the very white, abnormally white optic disc here from optic neuritis, where there's inflammation of the optic nerve. And this will be permanent damage. So in fact, what we do is you have to monitor vision during treatment with ethambutol. You have to have your visual fields and things checked before starting treatment, and then monitored throughout the treatment. But it can also cause peripheral neuritis as well. It can precipitate gout, and it's nephrotoxic. So very last finish, just on the last two slides, because we're at time, is just because we're technically in cardiorespiratory, is just to mention antibiotics in relation to endocarditis. This is quite a a complicated area. So I'm going to just give a little bit of a taster of it. But the very key thing is, why do people get endocarditis? Well, usually it's because you've got an abnormal substrate somewhere in the cardiovascular system. So this would be a prosthetic valve or a native valve that's particularly maybe been damaged. Maybe they've got a bicuspid aortic valve or something, or they've had, you know, these days it would be uncommon, but in the past, rheumatic heart disease or some form of congenital heart disease. And then you add on to that a bacterial source. So this could, and to be honest, these days it's probably most commonly an IV drug user injecting something horrible when they've cut the drug and inject it. But it can also come from dental procedures, which is why sometimes dentists will prescribe you an antibiotic. If you have a heart valve problem, they'll often then prescribe you an antibiotic before carrying out a dental procedure. Or it can come from an implanted device, or if somebody sticks a catheter into you somewhere and accidentally carries in some staphylococcus or some streptococcus or something into your bloodstream. It can also come from bowel surgery where you get strep bovis and things coming into the bloodstream from the gut. And basically what happens is you get a bacteria in the bloodstream together with a little bit of a thrombi somewhere in an abnormal valve, and the bacteria can seed into the thrombi and hide from your immune system. And that results in endocarditis. It's usually in the actual heart valves, but it's potentially, 24% of people are dead within 6 months of getting endocarditis. If you do find it on the right side of the heart, it's usually in an IV drug user because they're injecting intravenously, and therefore it lands on the right side of the heart first before being filtered by the lungs. Whereas if it's on the left side, it's usually on a native or a prosthetic valve. So, and you got to think about, that's only slide I have for that one. You got to just think about endocarditis. It requires very close relationship with the microbiologists, the cardiologists, potentially cardiac surgeons, to manage it, and involves intravenous antibiotics, and often it's combination antibiotic therapy. The commonest combination would be combining penicillin, like penicillin G, which is benzoyl penicillin, together with something like gentamicin. And gentamicin and penicillin have antibacterial synergy, so they work very well together and actually are more potent when used together to kill the bacteria. And of course, if you've had a source, you need to try and eradicate and remove that source in the future.
And I think endocarditis is a super important example of why you have to get cultures before you give the antibiotic. Because if you give the antibiotic first and then try and take cultures, you'll never find the organism for endocarditis, or very rarely. And then the subsequent treatment is just infinitely more difficult. So that, if you're suspecting this, diagnosis, then you need to get at least 3 pairs of blood cultures done before you give the antibiotics.
Yeah,
So,
usually at different times and from different places.
yeah. Yeah.
And
And
I think you have to have a high index of suspicion to find it.
yeah.
You have to think about it and think, could this be endocarditis?
Yeah, it's never going to be a barn door thing, I don't think, or rarely going to be barn door. And the other thing to just mention quickly is that anyone with a Staph aureus bacteremia needs to get an echocardiogram done because they might have developed endocarditis, because Staph aureus is a particularly bad bug for causing endocarditis. As you can see, it's the most common organism that causes endocarditis, and the type of endocarditis it causes is a particularly destructive one. So,
yeah. Okay, everyone. Anybody got any questions before we finish this masterclass and have a break for 25 minutes? Anyone want to answer any questions? No. Okay. what I'm going to do then is I'll put the music on, I'll give us an outro, and we will come back for the next masterclass at 11 o'clock. So we'll see you then. Go and have a decent stretch of your legs, have a coffee, and we'll see you back then.